Assalamu alaikum and hello everyone. I am Dr. Muhammad Fawad Khan. Today we will be discussing a very interesting neurological disease called neuromyelitis optica spectrum disorders, shortly called NMOSD. Uh, Before starting this presentation, I would like to say one thing that it is just a brief outline of this disease, and we will not go into the details. In future, inshallah, I would like to have separate videos on each aspect of this disease, like clinical characteristics, management, and diagnosis. So now let's begin. Neuromyelitis optica spectrum disorders are inflammatory disorders of the CNS characterized by severe immune mediated demyelination and axonal damage predominantly, targeting the optic nerves and spinal cord, but also the brain and brainstem. So, first thing is that it is immune mediated, it is an autoimmune disease. The second thing is that it is a demyelinating disease. And the third thing is that it specifically attacks optic nerves and spinal cord, as the name indicates, neuromyelitis optica. But it can also affect other regions like brain and brainstem. Initially, it was thought that it is a variant of multiple sclerosis, but with time, a specific antibodies were identified called aquaporin 4 antibodies, which are specific for NMOSD. So, an MOSD can be distinguished from the MS and other CNS inflammatory disorders by the presence of the disease-specific aquaporin 4 antibodies, which plays a direct role in the pathogenesis of an MSD. Aquaporin antigens are present in the CNS, particularly in the spinal cord. So, these antibodies are specifically target these antigens and called demyelination. So, in summary, it is an autoimmune demyelinating disease of the CNS, targeting specifically spinal cord and optic nerves, and the aquaporin 4 antibodies are very specific for this disease. Incidence is that it is more common in females like MS, 10 ratio 1. Female to male ratio is 10 ratio 1. The median age is of 32 to 41 years, and MOSD has a relapsing course in 90% or more of cases. So it has a very relapsing tendency. The core clinical characteristics on the top, as the name indicates, neuromyelitis optica, optic neuritis, and acute myelitis. These are the two main core clinical characteristics. The optic neuritis can be bilateral or rapidly sequential optic neuritis, causing visual loss. Like it can both occurs bilaterally at the same time. Both optic neuritis can occur in the both eyes. It can also occur alternatively, like firstly right eye and after some time the left eye is involved. It can also affect the spinal cord in the form of a longitudinal extensive transverse myelitis, also called LETM. In LTM, the spinal cord is involved of three or more than three vertebral segments. So acute myelitis can present in the form of acute lower limb weakness and bladder dysfunction. So a patient with visual loss and lower limb weakness with aquaporin 4 antibody positive is an MOSD. Other symptoms are core clinical characteristics are area postrema syndrome, which is a very interesting syndrome. Sometimes to our clinical setup, patient presents with vomiting and hiccups. As we know that if this area is irritated, then the patient have vomiting and hiccups. So it is called area postrema syndrome. It can present in the form of acute brainstem syndrome, like it can involve brainstem and then specific clinical features related to the brainstem area affected. It can present in the form of symptomatic narcolepsy or acute diencephalic clinical syndrome with NMOSD, typical diencephalic MRI lesions, symptomatic cerebral syndrome with NMOSD, typical brain lesions. So it can present in the form of optic neuritis, acute myelitis, in the form of area postrema syndrome, brainstem syndrome, cerebral syndrome, diencephalic syndrome. But for the last two, like acute diencephalic clinical syndrome and cerebral syndrome, we need NMOSD typical brain lesions. So it can be these are the core clinical characteristics. We will now go into the details of these syndromes because it is just a brief outline of this disease. For diagnosis, we need, as we know that for diagnosis of every disease, we need history examination and some investigation. So we have to take a comprehensive history, like a female in its middle age are present to us with the visual loss and lower limb weakness, and then you have to do the examination. On eye examination, you can see optic neuritis, optic atrophy, and on examination of limb you can see the upper motor neuron lesion in the lower limbs. So then you have to proceed for two tests. One is MRI brain and spinal cord, and the other is the aquaporin 4 antibody status. So neuroimaging characteristics of the NMOSD. It can has acute changes or as well as chronic changes. In acute, as we discussed earlier, there is a LETM, longitudinal extensor transverse myelitis. There is increased signal on sagittal T2 weighted, extending over 3 or more complete vertebral segments. Like a patient with optic neuritis and having LETM strongly suggest an NMOSD. In chronic, the features are same, but there is longitudinal extensio cord atrophy. Like the area is same, but there is extensio cord atrophy extending over 3 complete contiguous vertebral segments, with or without diffuse T2 signal changes. So in acute MRI, spinal cord MRI, we see longitudinal extensor transverse myelitis. There are contiguous 3 or more vertebral segments involved. There is increased signal change on T2. In chronic, there is atrophy of the spinal cord. Optic nerve if we do the MRI brain with also to see the optic nerve, there is unilateral or bilateral increase to T2 signal or T1 gadolinium enhancement within the optic nerve or optic chiasm. Relatively long lesions, example those extending more than half the distance from orbit to chiasm, and those involving the posterior aspect of the optic nerves or the chiasm are associated with NMO, neuro-myelitis optica. So again, on MRI brain with when you see the optic nerves, so you optic nerve, there is increase in signal intensity. As in the case of spinal cord, it involves contiguous 3 or more vertebral segments. So in case of optic nerve, there is an enhancement in relatively large area. So these are some MRI changes related to NMOSD. Now, what is diagnostic criteria? So if a patient has aquaporin 4 antibodies positive, then we need one core clinical characteristic, as we discussed earlier, optic neuritis or acute myelitis or area postrema syndrome. Positive test for aquaporin 4 antibodies test using best available detection method, that is cell assay strongly recommended. And exclusion of alternative diagnosis by doing as we do MRI. So MRI brain and spinal cord, it can also give alternative diagnosis and helps us to exclude alternative diagnosis. We can also do antibodies that is specific for MS to rule out other demyelinating diseases. So one core clinical characteristic, positive aquaporin 4 antibody test and exclusion of alternate diagnosis. So in short, if a female in middle age present to us with visual loss, lower limb weakness, MRI shows optic neuritis and acute myelitis, specifically LETM with aquaporin 4 antibody positive, and we exclude alternative diagnosis. So this is an NMOSD. Now, if there is a patient without aquaporin 4 antibodies or NMOSD with unknown aquaporin 4 antibody status, for this we need at least 2 core clinical characteristics. In the first scenario, when aquaporin 4 antibodies are positive, we just need 1 core clinical characteristic. But in this case, we need 2 core clinical characteristics that meets all of the following requirements. At least 1 core clinical characteristic must be optic neuritis, acute myelitis with LATM or area postrema syndrome. B is dissemination in space, two or more different core clinical characteristics. C is fulfillment of additional MRI requirements. So the amongst the two core clinical characteristics, one should be optic neuritis or LATM or area postrema syndrome. They should be disseminated in space. Like, no, there are 2 to 3 regions optic nerve. No, one should be optic nerve, other should be spinal cord or other region like in the brain or brain stem. And the third is that fulfillment of additional MRI requirements and negative aquaporin 4 antibody test and exclusion of alternative diagnosis. So, in summary, the diagnostic criteria: if the aquaporin 4 antibody tests are positive, we need one core clinical characteristic and exclusion of alternative diagnosis. If aquaporin 4 antibody status is negative or unknown, then we need two core clinical characteristics, and among them one should be optic neuritis or LATM or area postrema syndrome, and exclusion of alternative diagnosis. So these are the diagnostic criteria for NMOSD. Now treatment. If you are in a hospital and you diagnose this patient, so you have to start it on a high dose methylprednisolone 1 gram daily for 3 to 5 days. It is a grade 2C recommendation. If there is no response to glucocorticoids or not good response to glucocorticoids, then we can also treat with the plasma exchange. Plasma exchange is very effective if start early. So we take start from the IV methylprednisolone, and then we have also choice of plasma exchange. If acute insult is controlled with the help of glucocorticoids and plasmapheresis, and if the patient improve, then we can think about long-term immunotherapy. The long-term immunotherapy is given to the patient because it has a very relapsing tendency. So as the diagnosis is made, you have to start the long-term immunotherapy. For patients with seropositive aquaporin 4 antibodies, we suggest treatment with eculizumab, enabilizumab, or sertolizumab. We are available rather than other immunosuppressive agents. But in our setup in Peshawar, we haven't available these drugs, so we all mainly give rituximab to these patients. So as they have said that while eculizumab and enabilizumab are approved, many clinicians use rituximab, tocilizumab, or other immunotherapies for patients who meet NMOSD diagnostic criteria with or without aquaporin 4 antibody seropositivity. The immunosuppression is usually continued for at least 5 years because it has a very relapsing tendency, even if there is a single attack. The prognosis is not that much good. There is a stepwise deterioration due to accumulation of visual, motor, sensory, and data deficits from the recurrent attacks. Long-term disability and mortality rates are high. Guys, it was actually a brief outline of this disease. What we learned today is that neuromyelitis optica is an autoimmune demyelinating disease of the CNS. It mainly involves optic nerves and acute myelitis in the form of LETM, area postrema syndrome. The main antibodies are aquaporin 4 antibodies. The test we need is MRI brain and spinal cord and aquaporin antibody test. Other is that diagnostic criteria: if aquaporin 4 antibodies are positive, we need one core clinical characteristic with aquaporin 4 antibodies and exclusion of other diagnoses. If aquaporin 4 antibodies are negative or unknown, then we need two clinical core clinical characteristics. One of them should be optic neuritis or LTM or area postrema syndrome, and also exclusion of alternative diagnosis. Management includes in the acute setting is IV methylprednisolone with plasmapheresis. For long term, we need immunotherapy with eculizumab, enabilizumab, or sertolizumab, and we can also use the rituximab, which is not FDA approved, but in many clinical setups this drug is used. So I hope this was a very informative discussion. Inshallah, in future I would like to have more videos and in brief discussion. So thank you very much for your time.